have you ever stopped to think about, well, just how incredibly complex our healthcare system is? All the services, the people involved, and it's always changing, right? Today, on the deep dive, we're going to tackle that very world. Our plan is to really unpack the basics of healthcare delivery and, maybe most importantly, the crucial evolving role that nurses play. And just so you know, all our insights today come from a really solid source. Fundamentals of Nursing 11th edition by Potter, Perry, Stockert, and Hall. Familiar one for many of you, I bet.
Absolutely. And our mission for you, the listener, is simple. Cut through that complexity. We want to give you a clear, really engaging and practical handle on key nursing concepts. We'll touch on everything from patient care principles, clinical decision-making, safety, even evidence-based practice.
Yeah.
And the key is connecting that knowledge to the real-world hospitals, community settings, home care. We'll break down jargon, describe any visuals from the book, and definitely link it all back to those core competencies you need. The goal, get you up to speed quickly, thoroughly, maybe spark a few aha moments, but without overwhelming you.
Okay, perfect. Let's dive into this intricate world then. Discover how nurses are truly at the heart of it all, tackling challenges and really shaping healthcare's future. So, to really get a grip on the system, we first need to understand what nursing is at its core. The source describes it as a caring discipline, which means it's more than just treating diseases. It's about helping people get back their health, stay healthy, or, improve it, preventing illness too, and finding comfort and dignity, especially towards the end of life.
Exactly. And the American Nurses Association, the ANA, extends on that. They stress nursing's role in promoting well-being, comfort, dignity, even humanity for everyone, individuals, families, entire communities. It's deeply collaborative, relies on scientific discovery, but it's also facing some pretty significant pressures. Some research from Barra House back in 2017 really pinpointed 4 major challenges shaping nursing right now. First, you've got the aging baby boomer population who just need more health care. Then there's a shortage and uneven distribution of physicians, especially in primary care. Add to that, nurses retiring at an accelerating rate, losing all that experience. And finally, the constant uncertainty that comes with healthcare reform. It's a lot converging at once.
Yeah, when you lay it all out like that, it becomes crystal clear why strong clinical judgment, thinking critically, isn't just a bonus skill. It's absolutely fundamental. It's what lets nurses provide safe, quality care amidst all this constant change. Okay, so let's shift focus to the structure of care itself. Traditionally, the U.S. system is seen as having 6 levels. There's preventative, primary, secondary, tertiary, restorative, and continuing healthcare. It's important to remember these levels describe the scope of services and the settings where the care actually happens.
Right, and this is a common point of confusion we should probably clear up right away. Those levels of care are different from levels of prevention.
Yeah.
Levels of prevention, primary, secondary, and tertiary describe the focus of what you're doing, the goal of the health activity. Let me give you an example. Imagine a nurse in an ICU that's tertiary care.
Right.
That nurse practices primary prevention when they reposition the patient regularly. Why? To prevent pneumonia. They practice secondary prevention by giving antibiotics for pneumonia that's already there, aiming to treat it early. And they practice tertiary prevention by checking for, say, side effects from those antibiotics, working to reduce complications and improve long-term recovery. See the difference?
That makes perfect sense. Focus versus setting. Okay, so let's make those 6 levels of care more concrete then. Can you give us some examples, maybe drawing from that box 2.1 in the source, like preventative care? What falls under that umbrella?
Think screenings, blood pressure, cholesterol, cancer screenings, immunizations, definitely. Diet counseling, mental health counseling, even things like community laws, like seatbelt requirements. It's all about stopping problems before they start.
Got it. And primary care, that feels like the everyday stuff.
It often is. It focuses on overall population health, promoting wellness. It's where you get common illnesses diagnosed and treated, manage chronic conditions like diabetes or high blood pressure, get prenatal care, well baby checkups. It's usually your first point of contact.
Okay. Then secondary, or acute care, that sounds more serious.
It generally is. This covers urgent care needs, hospital emergency departments, acute medical surgical care, could be outpatient or inpatient, and things like radiological procedures, x-rays, CT scans, MRIs.
Right, and tertiary care.
That's the highly specialized stuff. Intensive care units, inpatient psychiatric facilities, specialized consultations like seeing a neurologist or a cardiologist for a complex issue. It's for the most serious or complicated health problems.
Makes sense. Now, what about when someone's recovering?
That's restorative care. The goal here is helping people regain as much function as possible after an illness or injury. Think rehabilitation programs like after a stroke or heart attack. Orthopedic rehab. Sports medicine fits here too, and home care services designed specifically to help with recovery and regaining independence.
And the last one, continuing care.
This covers long-term support services for people who need ongoing help. Settings include assisted living facilities, nursing centers, what used to be called nursing homes, and adult daycare centers. It's for chronic conditions or disabilities requiring long-term support.
That framework really helps visualize the whole system. But, we hear a lot about the U.S. system being fragmented, maybe inefficient, costly.
Yeah, that's been a long-standing issue, and that's really where integrated healthcare delivery, or IHCD, comes into play. It's basically a strategy to fight that fragmentation, the high costs, and the variable quality. IHCD involves creating networks of organizations, hospitals, clinics, providers that work together. They aim to provide a whole continuum of services for a defined population, trying to align resources better, boost quality, and control costs. You might hear about accountable care organizations, or ACOs. That's a key example of IHCD in action.
And a really practical model that embodies this is the patient-centered medical home. Can you tell us a bit more about that?
Sure. The medical home model really focuses on strengthening that physician-patient relationship. It uses a team approach. Nurses, medical assistants, nutritionists, social workers, pharmacists, maybe others, all coordinated. They work together with the patient towards specific health goals, making it very individualized. And crucial to this is information technology, like electronic health records, EHRs, to keep everyone connected and on the same page.
So coordination is key.
Absolutely. And the core principle underlying all of IHCD is patient-centeredness. That means the care must be respectful of and responsive to your individual preferences, needs, and values. Your values should guide the clinical decisions. It's about treating the person, not just the condition.
That's a crucial shift. So let's zoom in on nurses again. How do they contribute specifically in those primary and preventive settings we talked about, where the goal is keeping whole populations healthy?
Oh, nurses are absolutely vital there. Our source has a great table, Table 2.1, highlighting this. For instance, in school health, nurses aren't just patching scraped knees. They integrate health promotion right into the school day, providing education, linking health to learning success. In occupational health, nurses run programs in workplaces focused on worker safety, health protection, and disease prevention. It boosts productivity and keeps people healthier on the job. In physicians' offices, nurses handle a lot of primary care, diagnosis, treatment, and increasingly focus on health promotion. You see many advanced practice nurses managing whole patient populations now. And nurse-managed clinics, off-linked to universities, focus specifically on nursing services, health promotion, managing chronic diseases, teaching self-care. There's also block and parish nursing, where nurses work within specific communities, often faith-based, providing unique services like running errands or offering spiritual support alongside healthcare. And community centers often rely heavily on nurses to provide accessible, culturally appropriate primary care, especially for underserved groups.
So a really wide range of roles, even just in prevention and primary care. What about the more acute settings, secondary and tertiary care?
Right, so in hospitals, nurses are on the front lines. They're constantly using clinical judgment, critical thinking, assessing patients whose conditions can change rapidly, organizing care for multiple people, coordinating with doctors, therapists, everyone. Then you have intensive care units, ICUs. These are high-tech, fast-paced environments. Nurses need specialized knowledge, advanced skills. Patients are critically ill. Conditions change constantly. It's also the most expensive setting because the nurse-to-patient ratio is so low, often 1-to-1 or 1-to-2. Mental health facilities are also crucial. Mental illness is widespread, and nurses there work in teams to provide care, manage medications, offer therapy, always ensuring patient rights are protected, even during involuntary admissions. And we can't forget rural hospitals, those critical access hospitals, or CAHs. Rural areas often face significant health disparities, economic issues, isolation. Nurses in CAHs often work very independently, providing essential 24/7 emergency care, sometimes being the sole provider on site for periods. They need a broad skill set.
It sounds like nurses need to be adaptable across all these settings. Now, one area that seems incredibly important, especially for safety, is discharge planning. The source says it should start right at admission.
Yes, absolutely.
Yes.
It's crucial, especially because, as you noted, patients are often discharged quicker and sicker these days. Starting planning early helps prevent things like medication errors or avoidable readmissions. The goal is always a smooth, safe transition to whatever comes next: home, rehab, another facility. The nurse is central to this. They need to understand the plan early, get the patient and family involved and informed, implement the plan, and check that it's working. The source has a figure, Figure 2.1, which basically shows a nurse doing exactly that, providing clear discharge teaching, making sure the patient and family understand.
And there's a specific technique for checking that understanding, right? The teach-back approach.
Yes, and it's evidence-based. Instead of just asking any questions, which often gets a passive nod, you ask the patient or family member to explain the plan back to you in their own words.
Ah, so it actively confirms they've grasped it.
Precisely. It makes them active participants. And the Joint Commission actually mandates certain topics must be covered in discharge instructions. Medications, any follow-up needed. Dietary changes, tests, or procedures to schedule. Our source also details several specific discharge planning models in Box 2.2. There's Coleman's Care Transitions Program, which uses a transition coach and focuses on things like medication self-management and knowing warning signs. There's Naylor's Transitional Care Model, geared towards chronically ill older adults, emphasizing continuity with a dedicated transitional care nurse. And the High-Intensity Care Model, or GRACE model, uses a whole interprofessional team, NP, social worker, pharmacist supporting the primary doctor to manage complex patients at home.
Those models sound really helpful, but what stops discharge planning from working well sometimes?
Common barriers include, well, poor communication between different providers. Sometimes roles aren't clear. Lack of resources can be an issue too. Nurses are really key in overcoming these by being clear communicators, coordinating effectively, and advocating for the patient's needs.
Okay, so after acute care, if someone isn't ready to go straight home, they might need restorative care, right? To regain function.
Exactly. Restorative care aims to help people get back to their best possible functional level, improve their quality of life after an illness or injury. One major setting is home care. This involves providing professional services and equipment right in the patient's home. Nurses use a standardized tool called OASIS. That's the Outcome and Assessment Information Set to assess patients comprehensively and track their progress. Then there's rehabilitation. The World Health Organization defines this broadly as enabling people with disabilities to reach optimal function physically, sensorially, intellectually, psychologically, socially. It's not just for, say, a broken leg. It includes cardiac rehab, stroke rehab, mental health rehab too, and extended care facilities provide intermediate care medical, nursing, or custodial for people recovering or managing chronic issues. Within this, you have skilled nursing facilities, SNFs, which have licensed nurses available 204/7 for more complex needs like IV therapy or ventilator care.
All right, and that leads us to the final level, continuing care. This is for longer-term needs.
Yes, continuing care provides prolonged health, personal, and social services. Think individuals with long-term disabilities, people who are never fully independent, or those nearing the end of life. The need for this is definitely growing. Key settings include nursing centers or facilities, again, the current term for nursing homes. They provide 24-hour intermediate and custodial care. These facilities use something called the Resident Assessment Instrument, RAI. It's mandatory. It includes several parts, like the Minimum Data Set, NDS, to get a full picture of the resident's health, needs, and strengths, which then informs their individual care plan. Box 2.3 in the source breaks down the components of the RAI. Assisted living is another big one of the fastest growing types. It offers a more whole-like setting, more resident autonomy, but still provides help with daily living activities. The source has a figure 2.2, illustrating how nursing services there promote overall health. The big challenge: it's often private pay, so access can be limited by cost. Respite care is also under this umbrella, offering short-term relief for family caregivers. It's so important for preventing burnout. And adult daycare centers provide daytime services, social interaction, and supervision, allowing family caregivers to work or take a break.
And within continuing care, there's also palliative and hospice care. These often get confused.
They do, but there's a key distinction. Palliative care is a holistic approach for anyone with a serious, life-threatening illness, focusing on improving quality of life by managing symptoms, physical, psychosocial, spiritual. It can be provided alongside curative treatment. Hospice care, however, is specifically for patients in the terminal phase of illness when curative treatments are no longer the focus. The goal is comfort, dignity, and quality of life at the end of life. It's family-centered care. They share similarities, symptom management, interprofessional teams, but hospice begins when the focus shifts away from cure. Advanced practice nurses often play a huge role in coordinating and providing both types of care.
This really paints a full picture of the system. Now let's talk about some of the critical issues shaping healthcare today, starting with the big one, costs versus quality. They seem completely intertwined now.
They absolutely are. You have payment systems like the Inpatient Prospective Payment System, IPPS, and DRGs, diagnosis-related groups, where hospitals get a fixed amount for a patient's diagnosis. This pushes them to be more efficient. But the real shift is towards pay for value. Payment is increasingly tied to how well the hospital performs on quality metrics. For instance, the Hospital Value-Based Purchasing Program links a slice of Medicare payments to performance on things like patient outcomes and patient satisfaction scores, those HCA, HPS surveys you might get. The Hospital Readmissions Reduction Program penalizes hospitals financially if too many patients bounce back within 30 days. This really incentivizes better discharge planning and follow-up, where nurses are critical. You also have bundled payments, where one payment covers an entire episode of care, like a joint replacement, encouraging coordination. And the Hospital-Acquired Condition (HAC) Reduction Program cuts payments for preventable problems like pressure injuries or certain infections, things directly impacted by nursing care quality. There's a clear financial incentive now for safety and quality.
Our source mentions a table 2.2, outlining different payment models like fee-for-service, pay-for-performance, shared savings. It seems the goal is always pushing towards better value.
Exactly. And related to that is patient satisfaction. It's not just a nice-to-have anymore. It's a shared responsibility and directly impacts hospital reimbursement.
Right. And interestingly, the source points out that things like good communication, being treated with courtesy and respect, those interpersonal skills, often weigh more heavily on a patient's perception of care than the technical aspects. How they felt treated matters immensely.
It really does. Which leads us to another huge issue, the nursing shortage.
Yeah, we hear about this constantly. What's driving it?
It's that combination of factors again. The aging population needing more care, the nursing workforce itself aging and retiring, and nursing schools not always having the capacity to train enough replacements quickly. The Bureau of Labor Statistics projects significant job growth for nurses, and there's a big push, like from the Institute of Medicine reports, for more nurses to get their BSN or even doctoral degrees to meet future complex needs.
And does staffing actually affect patient outcomes?
Oh, absolutely. The evidence is strong, and Box 2.4 in our source summarizes some of it. Higher nurse staffing levels are linked to better outcomes, shorter hospital stays, fewer pressure injuries, lower mortality, fewer infections, and higher patient satisfaction. Conversely, when staffing is poor, you see more errors, more missed care. It has real consequences.
So if there are fewer nurses available, it makes those core nursing skills, time management, good communication, patient education, just compassionate bedside care even more critical, making sure every patient feels seen and cared for despite the pressures.
Precisely. And that's where nursing competencies come in as a guide. Frameworks like QSEN Quality and Safety Education for Nurses define the essential knowledge, skills, and attitudes needed. Things like patient-centered care, teamwork, evidence-based practice, quality improvement, safety, informatics. Box 2.5 mentions another set, the Massachusetts Nurse of the Future competencies. These frameworks provide a roadmap for development, and for hospitals demonstrating excellence, there's the Magnet Recognition Program from the ANCC. It's a high honor signifying excellent nursing practice, great patient care, and an environment that supports innovation. Magnet hospitals tend to have better nurse-sensitive outcomes, like fewer falls or infections. Box 2.6 outlines its 5 components, like transformational leadership and exemplary professional practice.
Okay, shifting gears slightly, technology, it's advancing so fast. Genetics, 3D printing, robotics, EHRs. How is this changing nursing practice?
It's changing a lot, no doubt. But here's the really crucial takeaway. Technology makes work easier, yes, but it never replaces the nurse's clinical judgment. Never. Think about an IV smart pump. It has safety features, dose limits, but the nurse still has to verify the rate, assess the IV site, troubleshoot alarms, use their critical thinking if something seems off. Technology is a tool, not a replacement for the nurse's sharp eye and brain. We're seeing robotics emerge more in direct care too. Robots assisting older adults, exoskeletons helping paralyzed patients walk, even telenursing robots for remote communication and assessment.
That sounds futuristic, but I imagine there are hurdles. Cost, privacy with cameras, just getting patients comfortable with it.
Definitely. High cost, ensuring that tech is truly ready, patient acceptance, privacy concerns. These are all real issues. Nurses have a huge role here in evaluating these tools, advocating for patients, and making sure professional standards aren't compromised by the tech.
What about telemedicine or telehealth? That seems more established.
It is. It uses electronic info and telecommunication, video calls, smartphones, remote monitoring to provide care from a distance. Big benefits are increased access, especially for rural areas, and potentially lower costs. But challenges remain, like inconsistent insurance reimbursement policies across different states. The bottom line with all technology is that nurses need to be involved in choosing and implementing it, always keeping the patient, their dignity, and their rights at the absolute center.
A final critical issue we need to touch on is healthcare disparities. What exactly are we talking about here?
Healthcare disparities are differences in health outcomes and also in things like access to care, quality of care, equity that exists between different population groups, groups defined by race, ethnicity, socioeconomic status, location, gender, etc.
And what causes these disparities?
They're closely linked to what we call social determinants of health, or SDOH.
Right.
These are basically the conditions in the places where people live, learn, work, and age. Things like economic stability or instability, access to quality education and healthcare, the safety of your neighborhood, social connections, all these factors deeply impact health. Figure 2.3 in the source visually breaks down the 5 main categories from Healthy People 2030. So things like poverty, poor communication between patients and providers, maybe a lack of culturally sensitive care. These all contribute to worse health outcomes for certain groups.
Which means nurses have a really important role in trying to bridge those gaps, right?
Yeah.
Promoting access, providing education that people can actually use, working towards health equity.
Absolutely. It's a fundamental part of nursing advocacy.
Wow. We've covered a huge amount of ground today. From the basic levels of care and the absolute central role of nurses, through integrated systems, tricky transitions like discharge, and these massive issues of cost, staffing, technology, and disparities. It really underscores how nurses are woven into every single part of this healthcare fabric.
It really does. And maybe a final thought for you as you continue your nursing journey. Think about how those uniquely human elements, your compassion, your critical thinking, your ability to genuinely connect with another person, that's your most powerful technology. That's what will truly shape a future where quality, equitable care is something everyone can access.
That's a great point to end on. Thank you so much for joining us for this deep dive. We really hope exploring this chapter together has given you a valuable edge, a shortcut to feeling more informed and confident, whether it's for your studies or your future practice. Remember, you're a key part of the deep dive learning community. Thanks for listening.